So welcome to the Navigator Financing Models information session. We are California Bridge, a program of the Public Health Institute. And a quick review of our agenda today. Like I said, I'm Elizabeth Woodford, Finance and Contracts Manager. We're also going to be hearing from Dr. Amy Mullen, Director and Co-Principal Investigator at California Bridge. And then we're going to be talking in detail about the Navigator Financing Models funding, discussing funding history and hospital expectations. I'm going to have our colleague Elizabeth Keating, Clinical Program Director, join to talk about DHCS policy update. We're going to hear from Sade Johnson, our Program Administrator. And we are going to also have Elizabeth talk about an upcoming event that she would like to invite folks to. And then we're going to end with a Q&A. So I'm going to go ahead and turn it over to Amy to talk about California Bridge.
Great. Welcome, everybody. It is so great to see you. Thank you again so much for joining us. So we have all been together embarked on this really ambitious goal of providing 24/7 access to high quality treatment for substance use disorders throughout California by 2025. And guess what? We are nearly there with all of your amazing hard work. We are really changing the landscape of SUD treatment in California. But we are not done yet. We need to continue to support our programs, to continue to keep them going and continue to support you and all of the amazing work that you are doing. And I'm excited for the next year or two of this work. So thank you for being here and thank you for being on this amazing journey with us together. Next slide. This is our California Bridge model. This is the revolution in healthcare that you are leading, and this is the California Bridge model in action. And this is how we are providing low barrier addiction treatment throughout our acute care hospitals. And what you can see is really these are the linchpins of our model: is the clinical champion, the clinical teams, but really that navigator. The key to our success is the navigator who is able to provide that peer support, education, and the really important linkage to ongoing treatment. So that is really what we're here to talk about today, is how we can sustain and expand this model of care that has been so successful across the state of California. So thank you all for being here again. Next slide. This is what you have done. This is our impact to date. 300,000 patients with substance use disorders, 241,000 people identified with opioid use disorder. And this is really an important piece, is almost 100,000 prescriptions for buprenorphine. We are one of, if not the largest access point in the state of California for people with opioid use disorder. So what you are doing matters, and it is critical that we are able to continue and expand this work, because we know that we are just scratching the surface of the need in our communities. So this is really a big kudos to all of you and to all of us for this work that we're going to keep on going and continue to grow and expand. Next slide. How are we going to do that? And that's what we are all here to talk about today, is how we can take all of that amazing clinical work, these fantastic results, and grow them, make them permanent, but not just that, expand it. Because as I said, we know that we're just really barely starting to reach that need. Part of what we're going to be doing for the next grant cycle is focusing on financing models, how we can make this financially sustainable and viable so that we can continue to grow and do this amazing work that you are doing. We have some allies in the state which have done some really great, fantastic work that we're going to build on. And that is that starting next year, the community health worker, the ED substance use navigator, will be an essential health benefit. So the substance use navigator in our emergency departments have been determined to be an essential health benefit that all Californians need to have access to through their healthcare plans. And that is really going to support us on our journey to make that financially viable. So the work that we're going to do together is to really work through that to make sure that they realize that essential healthcare benefit that the state has determined by next year. So this is just a preview to some of this work that we're doing. We also have some really fantastic ways to collaborate with community-based organizations, to access enhanced care management pilots. So I'm really excited about how we're going to sustain and grow this program coming up. And I hope that you are excited too. So with that, I'm going to go to the next slide and turn it back over to Elizabeth. Thank you all.
Thank you so much, Amy. I just wanted to add a little context for, how did we get here, and talk about the funding history of California Bridge. We started off a number of years ago with State Opioid Response 1, SOR 1, where the funding came from SAMHSA, flowing to DHCS, to Public Health Institute and California Bridge, to a small group of hospitals piloting the California Bridge model. It was so successful that DHCS did the behavioral health pilot project where they provided funding directly to hospitals. Following that, we had the CalBridge Behavioral Health Navigator Program, which many folks on the call today participated in, having a navigator in the emergency department for almost 300 hospitals in California. Those contracts ended for a lot of folks or are in the process of ending. And so we also were lucky enough to get funding from the Sierra Health Foundation to start doing the work around navigator sustainability with some small $25,000 awards earlier last year and a little bit this year. And then here we are now, the CalBridge Behavioral Health Navigator Program, Navigator Financing Models. Once again, money is coming from SAMHSA, flowing to DHCS, the Public Health Institute and California Bridge, and we'll be subcontracting that out to our hospital partners. So I wanted to provide a quick overview of the Navigator Financing Models funding. And right at the top, Navigator Financing Models is not just a continuation of the Bridge Navigator program. While hospitals will still be required to have a navigator hired for at least 50% FTE and stationed in the emergency department, hospitals will also be required to implement a revenue generation strategy for navigator services through one of several possible approaches, which we'll talk through. But achievement of these deliverables are going to require leadership of hospital administrators, involvement of hospital billing departments and business offices, and updates to electronic health records. This is a big lift from a cross-cutting group of hospital staff. So it's definitely not just a continuation of the Bridge Navigator program, but it's going to require the investment of a large group of people at your hospital. The first thing we want to talk about is eligibility. Who can receive these funds? These funds are intended for hospitals that have no mechanism in place to sustain at least one ED behavioral health navigator as a permanent position in the hospital budget. So hospitals with at least one sustained navigator are not eligible for this funding. For those hospitals that received funding under the CalBridge Behavioral Health Navigator program, those hospitals will have to have successfully completed the deliverables for their previous contract, or if they're currently under contract, be up to date on the deliverables at the time of their submission of the RFI form for this funding. And we need hospitals to have reported a minimum number of navigator encounters in their peak performance month of the hospital's CalBridge Behavioral Health Navigator program contract period. So the data that you provided while you were while you had a CalBridge Behavioral Health contract with us, you can look back, look at your peak performance month. When was the best month you had the most number of navigator encounters? Divide it by your total annual ED visits per HCI data of 2021, multiply by 12,000. And if you're over 4 per month, you would be eligible for this funding. Most hospitals are going to meet that eligibility. We have so many amazing hospitals that are just serving so many people in their communities through Navigator services, the majority of hospitals would meet this criteria. But if you have questions, you can reach out to NavigatorProgram at bridgetotreatment.org. For those hospitals that did not previously receive funding from the CalBridge Behavioral Health Navigator Program, you can apply, but you'll only be considered if funds are available. The funding for this work is estimated to range from $60,000 to $150,000 for a one-year contract, depending on the number of submissions received from eligible hospitals. The deadline is March 25th for priority consideration. Any submissions received after March 25th will be placed on our wait list. And we're looking to do a notification of results in April. I want to start reviewing the hospital expectations. As I mentioned, this contract deliverables will be a big lift. It will be a cross-cutting group of hospital staff that will need to support this work. So for phase one of the contract, we're looking to have a fully executed contract, and the hospital provides complete and updated contact information for a navigator if they're hired at this point, navigator supervisor, and a clinical champion. By phase two, in fall of 2024, we'll want to see that a navigator has been hired for at least 50% FTE if they hadn't already been hired by phase one. Monthly data reports on required metrics are up to date, and the reporting form is submitted. And we're also asking hospitals to submit a list of active emergency clinicians practicing in the ED. When you submit your form for this RFI, we're going to be asking you which navigator sustainability strategy will you be pursuing. If you select the community health worker billing option, these are the requirements for phase two. Holding a meeting with hospital leadership and staff responsible for billing and coding to explore billing for CHW services. Hold at least one meeting with Medi-Cal managed care plans to discuss contracting for CHW services, and submit a summary of progress on CHW billing based on the results of those deliverables, and attend a follow-up meeting with California Bridge if requested. If you select the enhanced care management services option, you'll need to establish protocols to identify patients with substance use disorder who are eligible but not receiving ECM services. Hold at least one meeting with Medi-Cal managed care plans to discuss contracting for ECM services, and submit a summary of progress, and attend a follow-up meeting with California Bridge if requested. The third option is an alternative sustainability partnership. And for phase two, we're going to be asking that you describe this alternative sustainability strategy, including partnerships that you'll be pursuing, hold a meeting with those relevant partners, and submit a summary of progress, and attend a follow-up meeting with California Bridge if requested. Phase three is going to be in spring 2025, and this is all contingent upon receiving additional funding from DHCS for this phase of work. The deliverables at that time are going to be the navigator continuing to engage with patients, reporting monthly data metrics. And then for each of those options, depending on what you had selected in your submission form, you will either need to develop billable documentation templates and share them with California Bridge. For CHW billing, for enhanced care management, establish documentation and billing procedures to provide and enroll patients in ECM, and develop an MOU or letter of support from external partners that includes support for the navigator with your alternative sustainability partnerships. In all of these options for phase three, we're going to be requesting a summary of lessons learned and your attendance at a follow-up meeting if requested. The data metrics that I mentioned, they are different from the previous CalBridge Behavioral Health Navigator Program funding. We are going to still ask for a number of ED and hospital encounters where a patient was seen by a navigator for any reason, broken down by race, ethnicity, and gender. And we're also going to be asking for ED and hospital encounters where a patient was treated with buprenorphine, methadone, and naltrexone. And now I'm going to turn it over to my colleague, Elizabeth Keating, to talk about the DHCS policy update.
Hi, everyone. Nice to see you this morning. My name is Elizabeth. I'm the Clinical Program Director for California Bridge. Many familiar names in the chat. Our team is so excited to support you through this new funding round through California Bridge. So there are three options, as my colleague Elizabeth Woodford just reviewed, for this sustainability strategy. There is no wrong option. So whichever you pick, option 1, 2, or 3, we are looking forward to holding your hands through this sustainability journey. I did want to call your attention to one recent policy update from DHCS that concerns item 1, which is the option to experiment with billing for community health worker services from the ED. So DHCS put out a draft letter with the intended audience being managed care plans about the CHW benefit. So that draft letter was released about a month ago, and comments were due about a week and a half ago, and California Bridge did submit a few comments with the intent of making the community health worker benefit as feasible as possible for you all from the ED setting. So that letter did state that within 1 year of publication of this all plan letter, when we do think the publication will be in the next couple weeks, that managed care plans are required to have an operable policy to billing from the ED for the community health worker benefit. So we are tracking this very, very closely. If you are a hospital that has a fairly high volume of Navigator encounters from your ED, we are working really hard with DHCS to make this feasible billing for you to generate enough revenue that you would be able to sustain that Navigator position. So our goal today is to make you aware that this draft letter has been put out into the world. Maybe some of you saw it, and California Bridge is tracking the guidance that's going to be released in this letter very carefully to make sure it works for you. Again, probably most feasible for hospitals that have high volumes of Navigator encounters. And of course, our Navigator team is always standing by to work with you to increase those Navigator encounters. So stay tuned for more, and know that we are going to be here with you as this policy develops. Turning it over to Sade, I believe, to talk a little bit more about what we need from you to hopefully be able to fund your hospital.
I'm just gonna screen share. Okay, can I get a thumbs up if you can see the website? Perfect. Good morning, everyone. I'm Sade Johnson. I am the woman behind NavigatorProgram. So you all get to see a face, a wonderful face behind that email box. So I'm just going to go through a little bit about the website. You can go to bridgetotreatment.org, and you can use our handy dandy search tool, which is wonderful. And you can write in Navigator Financing, Navigator Financing Models, and you'll be able to pull up to our page. So here we have an overview. We have the deadline for priority submission. We also have the complete request for information. You can review all this information on our website. We also have the eligibility criteria here as well, which you can review. The letter of agreement is here and linked if you need that. And then we have information on click here to complete the RFI. So I'll come back up to that, but first I want to talk about the FAQs. At the bottom of our page, we have the FAQs. If you have any questions, please check here first. And then if the question is not here, you can always email NavigatorProgram@cabridge.org. So just going to go through the RFI just for a couple questions that I've received so far. This is the RFI. It is linked on our website. Some important questions that I've received, just some things to note, is that the legal entity name needs to match your W-9. Okay, so confirming that your W-9 submitted to payments@phi.org matches the legal entity name on this RFI. That is something I want the sites to know, to make sure of, and to double check. Another thing to make sure of is if you are putting yes to, are you a health system, hospital foundation, or staffing agency submitted on behalf of the hospital selected above, If you select yes, there is an upload here to upload your letter of agreement. So those are just two things I want to draw your attention to in the application. The rest of it is self-explanatory, going all the way to the end of the application. So I'll stop there and pass it back to Elizabeth.
Thank you so much, Sade. I am just going to get back to my slides and share my slides again. Okay. Let's see if that's working. Okay, I think so. Okay, great. All right, so talking about prioritization and notification. So as I mentioned earlier, we are looking for submissions to be received by March 25th from all hospitals that meet eligibility criteria. Anybody who meets eligibility criteria will be offered funding. Submissions received after March 25th will be placed on a wait list to be considered if funding is available. And as a reminder, hospitals that did not previously receive funding under the CalBridge Behavioral Health Navigator program will only be considered if funding is available. And if you are eligible and your submission is complete, we plan to provide the notification of selection in April 24. And I can turn it back over to Sade to talk about the contract process.
For the contract process, once you've been selected, as most of you know, PHI would draft your contract and send it to the following people: the primary contact, the contracting representative, and an authorized signator. Will receive a contract via email from Public Health Institute, PHI. That email will have a contact person for contract-related questions. You can always reach out to the Navigator Program inbox for program-related questions. So just as a reminder, these contracts will be fixed price and deliverables based, and financial reporting will not be required. So once you've signed your contract and send it back to the contact person from PHI, they would then countersign, PHI will countersign the agreement, and then it will become fully executed and it will be sent back to you. Just a reminder, phase 3 is an option period, which means we will amend those contracts in fall of 2024 once we have committed funding from DHCS to support phase 3. So as of right now, once again, phase 3 is an option period. So deliverable reporting forms will be provided by CalBridge. To receive payments, applicants must submit the deliverables reporting form in an invoice, similar to how we did with Bridge Navigator Program, on or after the scheduled date in the contract. So I'll pass it back to Elizabeth.
All right, and Elizabeth Keating, if you want to talk about the upcoming event.
Yes, so I want to emphasize that we are here to support you on this sustainability journey. To that end, we are holding an in-person meeting in about 5 weeks. I think it's a month from this upcoming Tuesday. It will be in Oakland, California, and there are about 10 spots left available in this meeting. Some of you who are here today are attending, and this is going to be an opportunity to come together if you are in a position of creating administrative culture change at your hospital. So that is primarily, we are looking for the people who are going to be working with managed care plans, who are going to be implementing billing changes, who are going to be implementing changes to the public health policies in your counties and in your health system. So we would love to have you. The event is free to attend, and it will be in Oakland. And just for this particular event, there will not be a virtual component. Our goal for this meeting is to have the people who are most equipped to make culture change in their hospital come together so we can discuss these options and come up with strategies to move forward together. So the registration link will be sent out with the follow-up materials for this meeting, and we would really love to see you here. So even if you don't think you're quite the right person, or if you're not available on this day, we really encourage you to, if you do plan to apply to this funding, identify someone to attend this in-person meeting. It'll be with me, Dr. Alicia Gonzalez, and my awesome team, which is Kaya Renouf and Amy Lundstone, who many of you have interacted with as we've moved through these funding rounds together. So would love to see you there. Let us know if you have any questions.
Thank you so much, Elizabeth. Okay, and now it's time for our Q&A portion. We are going to be updating the FAQs on our website after this session. For any questions, go ahead and type them in the chat. Make sure you're addressing everyone, not just the host and panelists, and we can start addressing those questions. So I'm going to stop sharing and see what questions are coming up in the chat. I'm just going to scroll up a little bit because I wasn't able to see the chat while I was sharing my screen. And so I see a question from Jody that says, given there are 2 new metrics, will there be, again, some lead time for large health systems to retool their data collection to be able to collect and report out on these new metrics? So thank you so much, Jody, for that question. When the contract is signed, the data metrics are due on a monthly basis as long as there is a navigator in place. So given the notice that you have on the metrics in the RFI and the length of time it takes to execute a contract, I hope that that would be enough lead time for the large health systems to be able to adjust to these data collection metrics. But if you have some specific circumstances that would make this not feasible to start submitting data metrics by the time you need to in your contract, please email NavigatorProgram@bridgetreatment.org. And then Greta asked, where will we be able to find this recording? So everyone's going to be receiving a post-event email. Oh, that was actually answered in the chat. Post-event email, and it will be posted on our YouTube and website. Okay. Dina asks, is the funding being offered for a 6-month period until fall 2023? Yes. So what we're going to be able to do is offer at least 6 months until fall 2024. There we go. And once we have confirmation from DHCS that we have funding for the 3rd phase, we'll be able to amend contracts to add on for phase 3. Jennifer asks, if the navigator position is a permanent position in the hospital budget, but grant funding is still being sought to sustain the position, are we eligible? So navigator positions that are grant funded and those positions are going away if you don't have the CalBridge Behavioral Health Navigator funds. Those positions would be the ones that we're looking to fund. You don't have a sustainability solution beyond funding from the state. Dina asks, is the encounter criteria of 4 for MOUD encounters? Oh, I see. It is navigator encounters. So as you reported in your CalBridge behavioral health data metrics as a navigator encounter, which includes navigator encounters for any behavioral health substance use issue, we would want to have that be the basis for the eligibility criteria. Ross asks, we have funds from the last grant cycle to sustain our navigators through the year. Is there a requirement that those funds will be exhausted by a particular date in order to apply for this grant? No. We do not have a requirement that you have to exhaust your funds before applying for this funding, because this is a deliverables-based funding. We don't require financial reporting. And Dina asks, just to clarify, our hospital needs W-9, then how will we sustain option 1, 2, or 3 by 3/25? I'm not exactly sure I understand the question. So Dina, maybe you can rewrite that in a different way. April asks, how much would the funding be? It depends on how many submissions we receive. It is, we have a certain amount of funding, and if we get 100 submissions of eligible hospitals, then we can give more. If we get 180 submissions, we can give less. So it's really going to depend on how many submissions we receive. Dina asks, we have a sustainability plan that is not yet up and running. Would I qualify? Yes, absolutely. Please get some funding to support your sustainability plan if it falls into one of the 3 available buckets. Jin asks, could you break down the peak performance metric? I am confused about 4 encounters per month per 12,000 annual encounters. That's great, Jin. We have an FAQ on our website, and I just want to try and pull that up, or maybe someone else from the team could pull that up and drop it in the chat. But it is detailed also on the FAQ.
Yeah, I can also speak to that briefly, Elizabeth. The goal in having a minimum qualification was simply to make sure that all the hospitals that are going to receive this funding have invested already in doing this work. There are a lot of amazing hospitals, of which many of you are working at and are represented on this call, that have worked really hard to make the Navigator position valuable to the hospital and make sure the Navigator is a busy and productive member of the hospital team. And having a minimum qualification requirement for this eligibility is just to make sure that we are honoring the hospitals who have already done this work. So I know that sounds kind of vague, but we did create an algorithm that looks to honor the month that your Navigator was the most productive as your benchmark. We know there are many reasons why hospitals might have had gaps in Navigator services, so we didn't want that to disqualify anyone, while also making sure that we are prioritizing hospitals based on work completed. So happy to answer questions about that by email if you have it. But I would say don't overthink it. If you have a Navigator who's working busily in your hospital, who you're looking to sustain, this funding is meant for you.
Great. Thank you so much, Elizabeth. Let's see. Additional questions from Dina. We need to submit a W-9 and then submit our sustainability plan by deadline time. Yes, we need a W-9 submitted to payments@phi.org that aligns with the legal entity name you are using in your submission. And in that submission, you're going to be asked to decide what sustainability plan option you'll be pursuing, whether you're going to select to work on the CHW billing option, the ECM option, an alternative partnership option.
Yeah. I want to jump in here to answer Ross's question about telehealth. Amy Mullen, I don't know if you're able to come back on video for this, but telehealth counts. Yes, count your telehealth encounters. Amy, why do we want to count telehealth encounters? Do you want to speak to that? This is Ross in LA County asking about encounters by telephone.
Ross in LA County, great question. Here at California Bridge, we are huge fans of telehealth. We think telehealth is really key and critical to providing and sustaining that low barrier access. So 100%, please count your telehealth encounters and keep going with your telehealth encounters. Anybody else who's interested, we think it's a fantastic way to extend your reach and provide that low barrier access. So kudos to you.
Yeah, absolutely. Elizabeth Woodford, I'm going to let you answer Jody's question about past funding recipients.
Yeah, I just wanted to just add one more detail about the Navigator encounters piece, is that the data that we're looking at to look at Navigator encounters is what was submitted to us via the CalBridge Behavioral Health Navigator program. So if you had not been including your telehealth, we are going to have underreported data. So if that's the case, please email us at NavigatorProgram@bridgetreatment.org just to make sure that we are having accurate information in our data, because that's what we're going to be using to evaluate eligibility. So we want to make sure that that's correct. So if you're someone who has very few in-person encounters, but a lot of telehealth, and that might push you over the edge in eligibility, please reach out. Okay. And then the next question from Jody: to apply, does the site need to have participated in the supplemental and/or sustainability funding rounds, or just the year 2 BHN funding that sunsets 6/23? You do not have to have participated in supplemental or sustainability funding. You do need to have successfully completed your CalBridge Behavioral Health Navigator funding contract. Okay, so Terry says, I think I underreported because I only counted the patients I saw in person. Terry, can you please email NavigatorProgram at bridgetotreatment.org and make sure that this is not an issue for your hospital. Please provide the name of your hospital in that email.
Yeah, I also want to just continue to emphasize, don't overthink this minimum requirement. If you have been reporting and doing the work, you probably don't need to be worried. Very, very unusual to have a hospital that is reporting to us and doing the work who needs to be worried about this. So
yeah, exactly. Thank you for
Terry,
reemphasizing that, Elizabeth.
Please do email us, Terry, if you're worried, but if you are worried, you probably don't need to be. That's the whole point. And Dennis's question, Elizabeth Woodford, funding's running out right now. Will the hospitals that are running out of funding right now be prioritized?
Unfortunately, we are only able to go through the contracting process as we can. And so we aren't able to prioritize hospitals running out of funding.
We're moving as fast as we can and we hear you. We hear you. And just want to let you know, like, we're moving as fast as we possibly can, and hopefully being able to tell your hospital, like, funding is coming and it's coming as quick as we can get it out the door will help.
We're moving as fast as we can. That's why this whole application has a 2-week application period. DHCS wants us to move as fast as we can. So just know that. Absolutely.
Yeah, thank you. Thank you, Amy. Thank you, Elizabeth. Diane asks, if banking and W-9 information is on file from a previous CalBridge Behavioral Health Navigator program, is it required to submit forms? My recommendation is to just resubmit it. We often get feedback from our payments team at PHI that, oh, the W-9 is too old, we need a fresh one. So let's just cross the T's and dot the I's and provide all the forms fresh so we have nothing holding up your contract. Adam DS asks, our patient navigator left, but we're actively trying to find another. Will this qualify us? I realize we will have to hire by fall of 2024. If you do not currently have a navigator and that position is not sustained, then yes, please submit your form.
Yeah.
And reach out to the team. We'd love to help you find someone.
And Adam also asks, will we still need to have seen 4 patients a month if we don't currently have a navigator? Adam, that 4 patients a month was during your CalBridge Behavioral Health Navigator Program contract. So it's not looking at your current activity, but your peak performance during the period of time you were contracted under the CalBridge Behavioral Health Navigator Program. And Macy, yes, everyone will receive the slides in a post-event email.
Ross, I can answer this question a little bit. So the required coverage is on the plan side. So the letter that's going out is to the plans. And so the plans are required to have access to an CHW in an emergency department starting next year. So the benefit to us is that the plans have to make sure that their members have access to your son in the ED. So the plans are then required. So what we're hoping, and we're going to provide support and technical assistance for you to do this, is that your hospital will be able to get payment and contract with the plan because the plan is required to make sure these services are available to them.
Thank you so much. And I don't see any more questions coming in the chat. I can hang on for a few minutes and see if anything else comes up for folks. But please go ahead and check out the website. It has all the FAQs, all the documents, everything you need to submit your RFI form is there. And then if you have any questions, please email NavigatorProgram at bridgetreatment.org. It's like Ross has another question about LA
Yes.
Department of Health.
Yes, yes. So if LA is the managed care provider and the access to the emergency department, SUN or CHW is a required essential healthcare benefit, yes, as the Medi-Cal provider, the mandate is that you make sure that your network is adequate and that there is an adequate network of ED SUNs for your patient population. Exactly.
Thank you, Amy. And I see Rebecca has a question. Will contract amendments in the fall include additional funding for spring 2024 contracts? I'm sorry, I'm not clear on the option period. Yes, I'm sorry, that's very confusing. I agree. This is not a way we typically operate. We would typically want to just be able to fund the full amount of contract right at the beginning. But unfortunately, we don't have those funds in hand from DHCS for phase 3. So what we're going to do is issue contracts for phase 1 and phase 2, which is going to be some amount of money that we can't determine right now, but the total value of the contract, phases 1, 2, and 3, will be somewhere between $60,000 and $150,000. The portion that's phase 3 is going to be determined based on how the funding from DHCS. So you will have an amendment to the contract that is going to cover phase 1 and phase 2. We'll have an amendment to add on phase 3 in fall of 2024 once we get that confirmation. Any other questions bubbling up for folks? Harry asks, are there any resources available to help set up CHW billing? Great question.
This is something that we are going to be working on and have been working on with the Hospital Association and DHCS so that we will help to be able to answer some of your questions and ideally can help with billing templates so that we can help make this easy for you and for your hospital because we want you to be successful and we want this to work for every hospital.
And for anyone still listening, really want to emphasize to join that in-person meeting if possible on April 23rd. We are going to be creating our dream wish list of resources that you all need that then we will go out and create for you.
And there's a question from Dina. Can we charge Medi-Cal? I only know of audit and DAST billing.
Okay, audit and DAST are ways you can document a screening, brief intervention, and referral to treatment. Screening, brief intervention, referral to treatment is a billable activity. It is not required to be reimbursed from the emergency department. But if you do have a contract with a Medicare or a commercially insured payer, you can bill for an audit or a DAST. It just depends on if the payer is contracted or willing to reimburse you for that. For the community health worker benefit, which is a Medi-Cal benefit, the plans will be required to make sure that service is available. So they will be reimbursing for community health worker benefit from the emergency department starting next year. And if your plan wants to contract with you earlier, fantastic.
So many great questions are coming up. Well, great question from Rebecca. Will level, non-level bundled hospital billing be addressed on 4/23?
Yes. The other piece that is in the draft guidance from the Department of Healthcare Services is a way to do an add-on billing. Really technical, but there's that the CHW services can be billed as an add-on to the bundled payments that are received from managed Medi-Cal plans.
I think, Amy, in terms of sharing the all plan letter, I think we should wait to get the next version before sharing it out widely, because I know DHCS received a bunch of comments on it. What do you think?
Yes, just to know, we will be sharing, we will be updating, we're communicating with the Department of Healthcare Services on this all plan letter. And they have indicated to us that they're committed to making this work for you and for your hospital.
Yeah, I would say Diane's asking for a copy of the draft letter. Maybe just use the slide that's going to be in this deck. Just share that slide that we shared about the letter and say, we understand that a final letter is coming soon, and California Bridge will blast it from the rooftops when it's available for you to share.
And Rachel had a question, is the CHW benefit only for patients seen in the ED?
CHW benefit is a Medi-Cal benefit. The reason that we're focusing on the emergency department at this moment is because previously plans were not required. You could contract for a CHW services through the ED, but this will add the ED as an essential healthcare benefit as a location where a CHW's work needs to be supported by a managed Medi-Cal plan. So yes, 100% CHW services outside the ED should already be covered by the managed Medi-Cal plans.
Any other questions coming up for folks? These have been amazing, detailed questions showing just how much hospitals are already thinking about these complex issues. Okay, I'm going to invite folks to drop off, but if you do have any other further questions, please email NavigatorProgram@bridgetotreatment.org. Thank you so much.